Okay, so we are starting with week 3, part 2. In part 2, we're going to be talking about croup syndrome and nursing management for croup syndromes. Then we're going to move on and we're going to talk about some bronchiolitis and pneumonia um, and then we'll move on and we'll talk about failure to thrive and then talk about some other surgical conditions that are common in the pediatric population. For example, Hirschsprung's disease and intussusception. Um, and we'll end up talking about pyloric stenosis and nursing management of a child with all of these conditions. And then we'll end with urinary tract infections or UTIs and pyelonephritis. And of course, we'll talk about nursing, medical management and nursing management. All right, so now we're going to start off by talking about croup syndrome. Well, croup is really a term that is applied to a group of symptoms that are characterized by hoarseness, barky or a brassy cough, which is also known as croupy cough. Um, and there are varying degrees of inspiratory stridor and varying degrees of respiratory distress that is a result of the swelling or the obstruction in the larynx when we talk about croup syndromes. Now, for infants and small children, they have a small diameter of their airways. So, whenever there is any inflammation of their airways, they're easily obstructed because their airways, as you can see in this picture, is already very small. So, if you have any kind of edema in your airway, you're going to see, as in this one, the airway is even smaller, so it's like barely even open. So so when you have croup, you're going to see the narrowing as a result of the edema. So the stridor that you hear is the air trying to squeeze through that tiny little opening or through that narrowed airway. All right, so now we're going to move on, and we're going to start with the first croup syndrome. So croup syndromes then are described by the area that's involved. So we're going to start off by talking about epiglottitis. Epiglottitis is a serious condition that requires immediate medical care, and it has a very rapid onset. So with acute epiglottitis, there's obstruction of the supraglottic area, and it occurs most frequently in children between the ages of 2 and 5 years of age. And the cause is generally caused by Haemophilus influenza. Now, with the Haemophilus influenza vaccinations, the incidence has really declined, but it's most commonly attributed to viruses in older children. So some of the major symptoms are drooling, agitation, fever. They would have a sore throat, and then you would hear that stridor, and that stridor is usually aggravated when they're supine. So so often you want those children will want to sit upright, leaning forward. So they'll often want to sit in a tripod position. When they're in that tripod position, they're less irritable and less restless. And usually the child does not struggle to breathe. Then generally the breathing is slow and quiet, and that usually will facilitate better gas exchange. So you want to leave them in that position, and you want to make sure the environment is quiet. So the treatment would be, if the child is in severe respiratory distress, then they would have a nasotracheal or a tracheostomy would be considered. They would be placed on anti-inflammatory medications, and they would be started on antibiotics. And usually the symptoms will subside within 3 days. It's important that when a child does come in to the emergency department, that you never want to attempt to visualize the epiglottis with the tongue blade, or you don't even want to try to attempt to even get a throat culture. Just aggravate things, even make things worse. So as a nurse, it's important that you act very quickly and calmly, and you don't want to cause any more anxiety. All right, so now we're moving on, and we're going to talk about acute laryngotracheal bronchitis. That occurs, well, first of all, it's one of the most common types of croup, and it affects children less than 5 years of age. It's caused by viruses. Examples of some of the viruses that can cause acute laryngotracheal bronchitis are RSV, or respiratory syncytial virus, influenza type A and B virus, or parainfluenza types 3 and 2, and also measles and Mycoplasma pneumoniae. Those are some of the common viruses. The onset is usually gradual. There's usually a gradual onset of a low-grade fever, and children often have an upper respiratory infection first. Some of the major symptoms are the symptoms are worse at night. Crying and agitation makes it worse. And again, they'll have an upper respiratory infection, and they'll have definitely an inspiratory stridor, because there's narrowing of that airway, and the air is trying to get through that narrowed airway. They'll have a brassy cough. They'll have some hoarseness. They may have some dyspnea. They'll be restless and irritable, and they would have a low-grade fever. So, and as the airway narrows, the child will start to struggle to get that air in that obstructive airway, which causes that inspiratory stridor. So usually the treatment would be humidity and maybe nebulized. They might receive some nebulized epinephrine and definitely some anti-inflammatories to reduce the subglottic edema that is present. All right, so now we're going to talk about acute spasmodic laryngitis. Usually with acute spasmodic laryngitis, there's paroxysmal attacks of laryngeal obstruction that occurs at night. And there's generally mild to absent inflammation, and usually they might have had a history of previous attacks that lasted 2 to 5 days. This usually affects children between the ages of 1 and 3 years of age, and some of the major symptoms would be they present with a barky cough. They definitely have stridor. There's hoarseness. They're dyspneic, and there's restlessness. And usually any excitement can aggravate that dyspnea, so you want to keep things quiet and calm. So they're often anxious and frightened. So the treatment is they're often treated at home, usually with humidity until the cough is subsided. So often you can go and instruct parents to go into the bathroom, shut the door, and turn on the shower so it gets all humid. It gets humid and misty in there. Now, that's with if it's not severe. With moderate to severe cases, the child may be hospitalized for observation with cool mist, and sometimes they might start racemic epinephrine. Okay, the next croup syndrome is bronchial, or excuse me, bacterial tracheitis. And that's where there's an infection of the mucosa of the upper trachea. And croup and epiglottitis is a main feature of tracheitis. It's commonly seen in children who are less than 3 years of age, and it can lead to severe airway obstruction, which will eventually lead to respiratory arrest or distress. Some of the causes are Staph aureus, and that's the most frequently cause of bacterial tracheitis. Other bacteria are Haemophilus influenza or strep pneumoniae. So usually the symptoms would be they've had a previous upper respiratory infection, they've had a croupy cough, stridor is not affected by position, they may have had a high temperature, they would present with some thick purulent secretions, and these can contribute to the respiratory distress. And when there's severe airway obstruction, they're definitely going to have respiratory distress. And in that case, if they are having respiratory distress, they may have an endotracheal tube inserted and they may be ventilated. And the treatment would be antipyretics for the fever and antibiotic therapy. So it's really important as a nurse that you recognize and prevent any life-threatening airway obstruction. So if they're having increased respiratory distress and difficulty breathing, you need to let the doctor know, because they may have to intervene by putting in an endotracheal tube and sending them to the intensive care unit, ICU. All right, so now we're going to move on. We're going to talk about bronchiolitis. Bronchiolitis is an acute viral infection that affects the bronchioles. Most children develop bronchiolitis and pneumonia from subgroup A infections than subgroup B infections, and we'll talk a little bit more about that later down in the slide. But some of the causes are obviously there. Different viruses. There's a RSV virus, which is respiratory syncytial virus, parent influenza virus, or adenovirus are causes of bronchiolitis. It's important to know that children can be reinfected with RSV, with the RSV virus, if they have inadequate antibody response. So in that case, they're not able to protect themselves against subsequent infections. So the transmission is by direct contact with respiratory secretions. If you're less than 3 feet, and also if your hands touch your secretion, if your hands are touching the secretions, and then you touch your eyes. So then if you touch your eyes or other mucous membranes, it spreads to your nose and other mucous membranes. So it's important then when you have a child that comes in for bronchiolitis, and it's you need to do some very good hand washing before and after you touch the patient and leave the room. RSV strains there's 2 major subgroups. There's A, which is much more virulent, and then there's subgroup type B. So A is much more virulent than B, and most children will develop bronchiolitis and pneumonia from subgroup A infections more than B, subgroup B. So one thing that is important to know is that the survival of the secretions for of the RSV secretions. They last for several hours on countertops, gloves, tissue, paper, and those secretions, the virus lasts for a half hour on your skin. So it's like, being very vigilant with your hand washing is very important. So signs and symptoms. Initially, the infants will present with the upper respiratory infection. They'll have a runny nose, and they have intermittent fever, and they definitely will have pharyngitis, coughing and sneezing. They may have otitis media and conjunctivitis that may be present. And as the bronchiolitis, as it progresses, gets worse, they'll have increased coughing, wheezing, retractions, tachypnea, and their SATs will drop less than 92%. They'll have a fever. They won't want to eat because they're not feeling well, or they'll have poor feeding. All right, so the treatment for uncomplicated bronchiolitis is you want to treat the symptoms. So you want to give them oxygen as needed. So if their SATs are less than 92%, you want to give them oxygen. You want to hydrate them, but you don't want to give them too much fluids. You would give them their medications, and you would monitor their airway. So for severe cases, they may receive ribavirin. It's inhaled. It's an antiviral drug. And obviously, if they have a severe case, they would be in the ICU. So prevention for RSV, especially for high-risk children. So high-risk children would be those who are born prematurely, those who have heart disease, and those who are immunocompromised. So for those children, they would, during the RSV season, they would receive Synagist once a month intramuscularly, because they're high risk, and they're and you don't want them to get that, because they could become very ill if they end up getting RSV bronchiolitis. All right, so nursing management would be, they would automatically be placed on respiratory or droplet isolation and contact isolation. Nursing wise, you would monitor the respiratory status. So you assess their lungs, you assess and monitor their saturations. You want their saturation to be greater than 92%, but then again, you're going to look at the order and see what the doctor writes for the SATs, but generally they want them greater than 92%. You would assess and monitor for increased respiratory effort. So you would assess for increased nasal flaring. Are their nostrils flaring? Do they have supraclavicular and intercostal retractions or subcostal retractions? So you want to, turn the light on, lift up their shirt, and look at their breathing effort. You want to administer O2 nasal cannula or mask as needed. So it's going to be based on what their SATs are and their respiratory effort. You're going to suction their nasal secretions as needed. Because you have to remember that babies, especially if they're babies, they're obligatory breathers. They breathe through their nose. So if their nostrils are full of secretions, then their SATs will probably be lower. So if you suction them, their nostrils, and you notice their SATs will go up afterwards. Okay, and then also you want to elevate their head of their bed, at least 30 to 45 degrees, because you want their lungs to be able to expand, to be able to expand as much as possible when they're breathing. You want to administer any meds, so sometimes they might be on bronchodilators, and for their temperature they would be on antipyretics, or they might even be on Tylenol or Motrin just for comfort if they're irritable and fussy. You give them some Tylenol to calm them down. You want to monitor their IV fluids. Um, you don't want to give them too much fluids. You want to monitor their intake and output. So they would probably be on strict INO. And you want to assess their nutritional status. So feeds, you want to feed them small amounts and frequently. Or they might even be, if they're severely ill and they're severely tachypnic, they're increased respiratory distress, they're probably going to be NPO. So if they're tachypnic, you would hold their feeds. Okay. All right. So now we're going to move on and talk about bacterial pneumonia. So pneumonia is common in infancy, early childhood, and childhood. So bacterial pneumonia, usually there is inflammation of the lung parenchyma, and it's considered to be a serious infection. So there is usually an abrupt onset, and it usually can follow an upper respiratory infection, or it follows usually a viral infection. Okay? So usually the onset is abrupt. Generally, okay, I already said that, sorry. Signs and symptoms, the patient will appear very ill. So they have a fever, they'll be malaise, or kind of, tired, groggy. They have some rapid and shallow respirations, so they'd be tachypnic. They could have a cough and chest pain. But if they're an infant, they can't complain that they have chest pain, so they would be fussy and irritable. Older children, they would complain of a headache and chills. They might complain of abdominal pain and chest pain. Infants and young children, they develop more severe symptoms than older children. With infants and young children, they may be apneic, so they can have some present in the emergency department with apnea. They'd have episode of apnea. They could be cyanotic, and they have definitely have decreased activity level and decreased food intake. With infants, they can have a sudden fever, vomiting, diarrhea, and abdominal distension. And initially, they can have a hacking cough that is non-productive. Their breath sounds, they would have maybe some scattered growls. Now, when consolidation is present, the breath sounds will be very tubular, with no advantageous sounds. So on the X-ray, if there's consolidation is present, then you would probably hear those more tubular sounds, and you might not hear any advantageous sounds at all. All right, so as the infection resolves, then you'll probably hear some coarse growls, wheezing may be heard, and the cough will become more productive. So that's as the infection is resolving. Now, with pneumonia, transmission is the bacteria is usually introduced into the lungs, or the bacteria is from the bloodstream. Diagnosis for pneumonia, bacterial pneumonia, is confirmed by chest X-ray, and that shows pulmonary infiltrates, which reveal lobar consolidation. And in some severe cases, sometimes you'll have children or infants who have pleural effusions. That is not uncommon to see some kids with pleural effusions. All right, so lab work. So some of the lab work that you're going to see would be they'll get their CBC. Well, you look at their white blood cell count. They'll definitely have a gram stain and culture of the sputum for older children. On occasion, they might have a lung biopsy and aspiration. And of course, treatment would be IV antibiotics. Some antibiotics would be cefuroxime, cefotaxime, ceftriaxone. And on occasion, You would have a child may be on chest physiotherapy to clear the secretions, and usually those kids would be those or who are not able to mobilize, cough up their secretions. Maybe if they're developmentally delayed and they're bedridden, they would most likely be the ones that would have chest physiotherapy. Older children who are able to handle their secretions will not need to have the CPT or chest physiotherapy. All right, so for nursing management, you obviously are going to do your respiratory assessment. You would administer oxygen as needed. They would definitely be on IV antibiotics, IV fluids, and you would monitor INO. So they'd be on strict INO, and you would monitor their saturations. And then they may or may not be on nebulized bronchodilators. Most likely they probably will be on nebulized bronchodilators, but they may not. So prevention then would be pneumococcal conjugate vaccine, and that is recommended for infants and children 6 weeks to 59 months of age. The recommended schedule would be at 2 months, 4 months, and 6 months, and between 12 and 15 months. The California law now says that, or states that parents no longer can use the personal religious beliefs as a reason not to have their kids immunized. So the new state law took effect July 1st, 2015. However, this school year, kindergartners and 7th graders must show proof of immunizations. And young children who got their personal belief exemption approved before January 2016 will be grandfathered in. And according to that new law, they still must get immunized when they reach 7th grade. So they're not exempt. All right, so now we're going to move on and we're going to talk about failure to thrive. Failure to thrive is usually a sign that a child has inadequate growth that results from their inability to get and use calories that are required for growth. So usually the weight will fall below the 5th percentile of that child's age. And growth measurements alone are not used to diagnose failure to thrive. So there needs to be a persistent deviation from the growth chart. Okay, so it's important that when a child comes in with failure to thrive, you want to rule out other diseases or other conditions that may result in failure to thrive. And on this slide, these are other things that can cause failure to thrive. So you want to rule out diseases or conditions that result in failure to thrive, such as there's cystic fibrosis where they have inadequate absorption. There's celiac disease or vitamin or mineral deficiencies or biliary atresia or hepatic disease. These all can be the reason why there is failure to thrive. There's conditions where there's increased metabolism. So congenital heart disease, they can have failure to thrive. Hyperthyroidism can the child can have failure to thrive, or chronic immunodeficiency. And then there's other defects where there's defective utilization. So there's genetic anomalies like trisomy 12 and 18 or congenital infections where the child may be failure to thrive. So other conditions need to be ruled out when a child comes in for failure to thrive. Okay? All right, so there's many factors that can lead to inadequate caloric intake. So there's poverty. So maybe because a mother doesn't have the funds, they might, for example, dilute the formula with more water to make that formula last longer. because they're homeless, or they may be uninsured and they don't have enough money. Their money ran out, or they may not have a primary medical doctor. Um, so, how other factors why a child might be have failure to thrive is health beliefs. Um, so there are many different reasons. There's the parent might have inadequate nutritional knowledge. So there might be some, cultural confusion, or there might be some cultural reasons why the child is not getting enough food. Maybe they're not aware of appropriate food selections, or the parent might have some cognitive impairments, or you might have teens, young girls who are too young and they don't um, they have inadequate parental role models to help them and how to care for their baby, so they're not feeding their baby enough. Or a mother might be breastfeeding and there's insufficient breast milk, um, because maybe she's fatigued, she's exhausted, so there's insufficient breast milk, or there's poor release of milk, or there's insufficient glandular tissue. So there's many different reasons why the baby might not be getting enough milk, breast milk, if she's breastfeeding. And then there's feeding resistance. On the child's part, which would be the result of non-oral nutritional therapy. So, for example, you have a premature infant who has been on an endotracheal tube and on ventilation for most of his early life, so they lacked that oral stimulation, and then now they've been extubated, and now they don't know how to suck. Um, and they don't know how to. They have difficulty sucking and swallowing. And then you could have conditions where there's cleft lip or cleft palate. Is repaired late, so as a result, the child was not getting enough adequate nutrition, adequate calorie intake, and adequate nutrition. So then, for failure to thrive, the prognosis is going to be related to the cause. So you want to treat the cause. So if they have a heart defect, you want to give them more calories. If they don't have enough money, you want to get them hooked up with the correct services, so they have enough formula to last them. Some of the long-term consequences of malnutrition would be they would have below normal intellectual development, they'd have poor language development, poor reading skills, and also there's an increased incidence of behavioral disturbances as a result of failure to thrive. All right, nursing considerations are that maybe you want to provide a positive feeding environment. You want to provide non-judgmental care. So you don't want to be judgmental about why the mother was not feeding their baby enough. And then when this child is in the hospital, you want to have some primary nurses or consistent caregivers while the child is in the hospital, so you can develop a rapport with the mother, and develop a positive relationship with the mother. So you want to have some core nurses should also feed these children to adequately assess feeding problems and develop feeding strategies. But then also you're going to have an occupational therapist also involved, and you're going to have a nutritionist involved. So the goals of nutritional management is that you want to increase caloric intake. So they would probably have more calories added, have more calories per ounce in their feeds. They might even need to be on gastric feedings, maybe bolus or continuous feedings at night, so they can get enough calories. And then also you would have a structured feeding plan. So you want to have scheduled feeding times. And you have step-by-step instructions for preparing formula for the mother. But then also, I don't have on this slide, is that you would definitely have a nutritionist involved. who would come and talk with the family. So you want to have a family systems approach. So all family members should be included in the plan. And then there's a multidisciplinary approach. So you'd have the primary medical doctor, nurses, mental health professionals, social workers are involved. And then occupational therapy is involved in feeding and teaching the parents how to feed. All right, so now we're moving on. We're going to talk about Hirschsprung's disease. With Hirschsprung's disease, it's a congenital aganglionic megacolon. So what happens is that there's because of the it's a congenital anomaly, it results in mechanical obstruction from inadequate motility of part of the intestine. So the term congenital aganglionic megacolon describes the primary defect where there is no autonomic parasympathetic ganglion cells in the submucosal and mesenteric of one or more segment of the colon. So essentially there's no nerve innervation. So there's a lack of peristalsis, and the internal sphincter of the rectum does not relax. So there's an accumulation of intestinal contents, and there's bowel distension proximal to the defect. So you have what is called megacolon, which we will see in, I believe, our next slide. So here is megacolon. There's a distended sigmoid colon, and then this is the aganglionic portion. So it's it's distended, so it's called, also known as megacolon. And again, because of the lack of peristalsis, there's an accumulation of intestinal contents of the bowel. There's an accumulation of intestinal contents, and bowel distension occurs proximal to the defect. And the aganglionic portion always includes the rectum and some portion of the distal colon, but the entire colon or part of the small intestine may be involved. So so the definitive diagnosis would be through a rectal biopsy. You would do they would go for a biopsy, and they would look. There would be evidence of there would be no aganglionic cells. They would not be present. All right. So then, in the neonate, diagnosis usually is made early because there's intestinal obstruction, there's abdominal distension, and there's feeding intolerance, and there's usually a bilious emesis. The bilious emesis is present but is delayed, or there's no passage of meconium. Now, with infants, they'll have failure to thrive. They would have constipation, abdominal distension, vomiting, and diarrhea, and they would look ill. Now, in older children, a careful H&P and chronic, which would show evidence of there's a chronic pattern of constipation. There's ribbon-like stool, which is foul-smelling. There's abdominal distension, and there's actually a visible peristalsis, and there's a palpable fecal mass. Now, so if the aganglionic segment is short, then the rectum will be empty, and the internal sphincter will be tight, and there will be leakage of stool. All right, so the pre-op for surgical would be you want to clean the bowel. So before you're going to go for surgery, you're going to clean the bowel, and obviously you're going to usually the current treatment is go lightly. and you would have they would have go lightly. Either they can drink it or they have it by be given by NG, nasogastric tube, and then you'd have some rectal irrigations would happen. Um, and then they would have systemic antibiotics, uh, and even pre-op they would have daily abdominal circumference measurements are recorded, and also parents need to be taught colostomy care because they are going to have a temporary colostomy. So this for surgery, then there's a two-stage procedure. The first stage is they're going to remove the aganglionic portion of the bowel, and so then that will restore normal motility, and it will preserve the function of the anal sphincter. Then a temporary ostomy is created proximal to the aganglionic segment, which relieves obstruction and allows the dilated bowel to return to its normal size. All right, then the second stage, that is done usually 6 months later. And on the second stage, they would do a Suave pull-through. And what that is that they pull the end of the normal bowel through the muscular sleeve of the rectum. And when they and at that time when they do that, the ostomy that they had, the temporary ostomy, is closed at this time. So so then the home care would be, caregivers should be encouraged to provide, after the first surgery, they would be encouraged to provide colostomy care. So they should be taught skin care. They should be taught how to empty the bag, how to change the colostomy bag, as well as monitoring for any problems. They should be adept with colostomy care. Some families may require financial assistance in psychological counseling or a referral to social services or other services. And a referral to a home health agency for home nursing visits may be needed. And, you know, I've taken care of a lot of parents where the parents, the mother, the caregiver could not, you know, change that bag. It was just too much for them to bear. So you have to find somebody in the family. If the child is old enough, then they can learn how to do it also. But, you know, you have to have a parent, somebody else in the family that can also learn how to change those bags and do ostomy care. Okay, so now we're going to move on and we're going to talk about pyloric stenosis, or hypertrophic pyloric stenosis. So in this slide, you see the image of a hypertrophic pyloric stenosis. That's this top one. So what happens is that the circular muscle of the pylorus thickens, and as a result, there's hypertrophy, and it causes constriction of the pylorus and obstruction of gastric outflow, and there is hyperperistalsis. So in our second image, what happens is they have the surgical repair, so the circular muscle fibers then are released. So then now you have, it's not stenotic anymore. So usually the cause is unknown, but what happens is that circular muscle of the pylorus thickens, causes constriction of the pylorus and obstruction of gastric outflow. So usually in the first week of life, the symptoms are usually the infant will present with projectile vomiting. They'll be dehydrated because they haven't been able to keep any feedings down, and they'll have weight loss, and they'll probably, you know, come in with metabolic alkalosis and failure to thrive because they haven't been able to keep their feedings down. So with metabolic alkalosis, they're going to have a low sodium, they're going to have a high pH and high bicarb. So some of the clinical manifestations would be obviously emesis that contains milk or formula. It's not bile. Emesis usually starts in the second and third week of life, and sometimes as late as five months. So gastric peristalsis may be visible on examination, and they will present sometimes with an olive-shaped mass, may be palpable in the epigastric region and to the right of the umbilicus. So epigastric peristalsis may be visible on examination, and you may see an olive-shaped mass, may be palpable in the epigastric and to the right of the umbilicus area. So management pre-op would be you obviously have IV fluids with electrolytes. You want to correct any alkalosis. You would insert an NG tube for decompression of the stomach. They probably may even be on gastric suctioning. And the surgical treatment is pyloromyotomy. And we already showed you that in the previous slide. Post-op management would be vomiting is really not uncommon during the first 24 to 48 hours. You would give them antiemetics, IV fluids. You would monitor the vitals, their intake and output, and electrolytes. And then for feedings, you start them off with very small quantities and at frequent intervals, and you would burp them frequently. And it's not uncommon that they would vomit also post-operatively. Okay, so now we're going to move on and talk about intussusception. With intussusception, it is one of the most frequent causes of intestinal obstruction in children between the ages of 3 months and 3 years. And the cause is not known. Although some cases may be caused by hypertrophy of the intestinal lymphoid tissue as a result of some viral infection, but really the cause isn't known. The pathophysiology then is if you look at our slide, what happens is the proximal segment of the bowel telescopes or goes inward, telescopes into a more distal into a more distal portion of the intestine. So what happens is the mesentery is also pulled into the bowel. So the mesentery, as a result, is compressed. So that causes lymphatic and venous obstruction. And as a result, there's an increased pressure and edema in the area of the intussusception. And the end result is you're going to have ischemia. You'll have some blood and mucus leaks into the intestine. So this is the cause of the current jelly stools. So they have current jelly stools. The common site is the ileocecal valve, where the ileum telescopes into the cecum, and then into the telescopes then into the colon. Okay, so the signs and symptoms then, they'll have acute, sudden acute pain, they'll have colicky abdominal pain, they can have intermittent pain, and they'll have current jelly stools, and later in the disease they'll have abdominal tenderness and distension. So usually with intussusception, the first line of treatment is do a hydrostatic reduction. That's really a barium enema, where the force of that enema exerted by the flowing barium will sufficiently push the telescoping portion of the bowel into its original position. Now, I mentioned a barium enema, but now, barium enema, but now water-soluble contrast and air pressure are now being used to reduce these intussusceptions. So usually, you don't want to do a reduction It's not recommended for children who are in shock or if they have a perforation, but usually they'll do the hydrostatic reduction, um, you know, sometimes a couple of times before they go for a surgical intervention. So some nursing considerations are: if a child presents with severe colicky abdominal pain with vomiting and has a current jelly-like stools, this is really considered to be a significant sign of intussusception. So the nurse should educate the caregivers on the non-surgical correction of intussusception. And they should also discuss the risk of reoccurrence, because it is not uncommon for it to reoccur even after you've done a hydrostatic reduction. So you need to let them know that, okay, we're going to do this hydrostatic reduction, but there is a risk of reoccurrence. So, and oftentimes they might do it a couple of times. But if it's not successful, then surgical reduction or bowel resection may be done. So it's really important that all stools must be examined before hydrostatic reduction or surgery is done. Because if the child passes a normal brown stool, it usually indicates that the intussusception has spontaneously reduced itself. So this should be reported immediately to the medical doctor, in which case the course of treatment may change. So after the hydrostatic reduction, the nurse should observe for the passage of barium or water-soluble contrast. So then for multiple reoccurrences, a laparotomy is done, and surgical reduction or bowel resection will be done. All right, so now we're moving on. We're going to talk about UTIs, or urinary tract infections. So they are the second most common infection in children. And usually a UTI is infection of the urinary tract, and it may involve the lower urinary tract, which is the urethra and the bladder, or the upper urinary tract, which involves the ureters, the renal pelvis, and the renal parenchyma. So the term UTI is applied to really the presence of significant numbers of microorganisms anywhere in the urinary tract, except the distal, or the 1/3 of the urethra, which is normally colonized with bacteria. So some of the causes, or the majority of the UTIs, are caused by E. coli, other gram-negative enteric organisms that are common to the anal area, the perineal, and the perianal areas. So other organisms such as Proteus, Pseudomonas, Klebsiella, and Staph aureus, and Haemophilus are other organisms that may be present. So some contributing factors for UTIs are: there are many contributing factors of why a child develops UTI. One of those factors is their anatomy, their any physical or chemical properties of the child. So for females, their short urethra, which is 3/4 inch, as opposed to males, there's a shorter distance for the microorganism to travel, as well as the possibility of contaminated urine return to the bladder at the end of urination. Now with males, they have a longer urethra, and there is the antibacterial properties of the prostatic secretions that prevent entry and growth of pathogens. So I would say you probably see more females with UTIs because of their anatomy, their shorter urethra. Also, incomplete emptying of the bladder may result from reflux, where there's an anatomic abnormality that involves the ureters, or there's incomplete emptying of the bladder. So, for example, incomplete emptying of the bladder you would see with a neurogenic bladder, or a child is holding back urine even though there is an urge to go. So some other factors that can cause UTIs would be and in having an indwelling catheter, or if they need to catheterize themselves, they have a neurogenic bladder and they need to self-cath. Antimicrobial agents that alter a child's normal perineal flora, which allows easier colonization of urinary pathogens, um, is another factor. Tight clothing or diapers or poor hygiene. Bubble baths and shampoo can irritate the urethra of both boys and girls, causing painful urination. So you want to make sure that children are have adequate fluid intake, because it lowers the concentration of the pathogens. So encourage fluids, and cranberry juice is recommended. Oops, sorry, I didn't change my slide. Okay, so for newborns and children less than 2 years of age, they usually will present with non-specific symptoms. Newborns might present with GI-like symptoms. Maybe they might have fever. They might present like they have sepsis. They might have some vomiting, diarrhea, and abdominal distension, or they might be jaundice, or they just have failure to thrive because they haven't been eating, or they can have some feeding intolerance. Other symptoms would be irritability. Maybe they're squirming, they have infrequent voiding, or they have a persistent diaper rash. Some classic symptoms for children over 2 years of age would be enuresis or daytime incontinence, fever, strong smelling urine, flank pain, and increased urinary frequency. Symptoms for teenagers then, for lower tract infections, would be frequent and painful urination, voiding small amounts of urine. Symptoms for upper tract infection would be fever, chills, flank pain. So the therapeutic management that would be, you would get a culture before starting antibiotics and sensitivities and a UA, and you would administer antibiotics to get rid of that bacteria. All right, so now we're going to talk about pyelonephritis. So that's an infection of the upper ureters, the renal pelvis, and the renal parenchyma. So it's an infection of the upper urinary tract. So for diagnosis then, a thorough history and physical, a UA, and urine culture are usually done to confirm bacteria in the urine. So with pyelonephritis, the treatment is you want to administer antibiotics for a maximum of 48 hours, and obviously you want to obtain blood culture and urine cultures, and then you would do some radiological evaluation. You would want to look for renal scarring, which can develop with initial infections. If they have high fever and chills, this is usually accompanied by flank pain and severe abdominal pain and leukocytosis. Other conditions are obstructive uropathy. So with obstructive uropathy, there's, I'm sorry, I forgot, on the treatment would be renal ultrasound or a VCUG, which is a voiding cystourethrogram, and that is a test that's done where you view the urethra and the urinary bladder. So you're looking at the anatomy, looking to see if everything in the anatomy is fine or not. All right, so now we're going to go on and talk about obstructive uropathy. So usually there is a high frequency of obstructive uropathy in young infants and boys, and what this refers to is there's some kind of structural or functional abnormalities of the urinary system that interfere with urine flow, and is usually characterized by dribbling of urine. The child is straining to urinate. There's a decrease in the force and size of the urinary stream. So if there's an anatomical defect, surgical correction is required. So they might have a reflux or a bladder neck obstruction. And of course, when they come in and they suspect pyelonephritis or even obstructive uropathy, they would do that VCUG or renal ultrasound. All right, and that is it for week 3, part 2.